I just got a notification that we're live. It's a nice picture of you looking thoughtful.
Yeah.
You see the big brain turns post?
Sorry?
You see the big brain turns post?
I did, yeah. I did see that. I think we're live on IG now.
Awesome.
Make sure the audio's on.
See the big brain turns post?
Yep, we are.
Yeah.
Great. People are coming in. Awesome. Hey, everyone.
Loving it. Well, we had someone and we lost him.
We have a brain turn starting up, right? Winter session?
Brain turns winter session coming up. Announced today.
That's awesome. I saw the post. It's awesome. It's exciting.
Yeah, it's going to be a single day event. It's going to be a teaser of next summer, basically.
Next summer should be big and strong. We got to make it viral again. It's great.
Hey, Jordan,
I want to come back.
Yeah, we'll get you back. Good. Do you want to test some of your slides and your audio and everything?
Yeah, I think Andrew's got the slides. So.
Oh, okay. Yeah, your audio is a little bit garbled. Nitesh, do you hear it okay?
It's garbled for me as well.
It'd be a connection thing. I think Andrew's having some sign-in issues. Keeps popping in and popping out.
Is it better without the earphones?
Oh yeah, much better. Yeah. Well, welcome. It's 4 o'clock, so I'll just, we'll start introducing everyone while Andrew comes on. Hopefully he's able to sign in okay. But welcome everyone to another edition of Tumor Talk. This is our webinar that we do weekly where we highlight recent publications of the Journal of Neuro-Oncology. And today we're, excited to have Jordan Jones and Andrew Markov from Australia. So this is actually, it's the future there, right?
It's the future there, that's right.
It's the future there. How's tomorrow? Is it better than today?
So far, so good.
So far, so good. Great. Well, we'll give Andrew just a minute, but excited to have you guys on board. I think the paper we're highlighting today is very interesting. And we're talking about basically the serum microRNA as a biomarker for postoperative monitoring in glioma. And I know this is a hot topic, and I think that your guys' paper is fantastic. So I'm really happy to have you. We're not sure if Jason Sheehan will join us today, but we have Nitesh Patel, who's chief resident at Rutgers. And why don't you go ahead and introduce your team?
I think Andrew's arrived.
Yeah, good morning. I've just joined. Thanks a lot, Randy, for inviting us to this webinar series. Hi, everyone from Melbourne, Australia. Yeah, I'm a neurosurgeon at University of Melbourne and Royal Melbourne Hospital, which is the major sort of neuroscience centre, neurosurgery hospital here in Melbourne. And yeah, it's good to be able to talk to people around the world. We've actually just come out of a 3-month coronavirus lockdown as of today, so we're all looking towards the summer. I think you guys are heading into the cold weather.
Yeah, we're probably going into the next one. Who knows? So.
Yeah. Definitely seems like it.
And Jordan there is a neurosurgery registrar or resident, as you guys call him. He's kind of halfway through his training, and it's taken a couple of years out to do a PhD. So that's under our supervision. So this has been his major project for the last couple of years.
Fantastic. Yeah, you can jump right into it. Basically, the format's about 15 minutes or so. You guys can present your work, and then we can have a discussion about it. And if you want, you can give some history about how you got interested in it. And,
Yeah, I'll do that. I've got a couple of background slides.
Perfect.
So yeah, I'll just talk for about 15-20 minutes, and then we can have a chat. Yeah.
Sounds perfect.
30 minutes total the seminar.
Yeah, we keep it nice and short so people stay interested.
Yeah, that's good. I'll see if I can Let's see if I can share my screen here. Here we
Yeah,
go.
no problem. And while you're doing that, I'll let you know that we actually, so this is live streamed on Instagram Live, and it's also live streamed on YouTube, and it'll be available on YouTube so you can share it with colleagues and residents and
Yeah,
whatnot.
that'd be good. We can send them the link. Yeah.
Absolutely.
All right. Can you see a talk there coming up now? You should be able
Perfect.
to.
Yep.
Yeah, great.
Yep.
Perfect.
Got no disclosures, by the way. So this is the paper that we're talking about that was published in JNO recently, and it's entitled "Serum microRNA is a biomarker for postoperative monitoring in glioma." This is a whole world of circulating biomarkers that's really kind of a hot topic in the last few years in cancer and more recently in gliomas and in brain tumours. We've actually been looking at this for quite a few years, and you know that the problems with management of gliomas at the moment, there's a couple of problems with monitoring. So currently, after patients have surgery and a STUP protocol or radiotherapy or chemotherapy, we usually follow them every few months with an MRI, contrast enhanced MRI. One of the problems with neurosurgery is we can't do frequent biopsies like in some other cancers because obviously it involves intracranial surgery, and we can often only get very small biopsies. So other tumours, they can do large resections of metastases or frequent just radiological needle biopsies. So we can't do that. And the other problem is that a lot of the diagnosis subclassification needs to be improved. So this has been a big focus of glioma genetics and sequencing in the last few years. But particularly in low-grade gliomas, the prognostic methods we have are not that great sometimes. Like for instance, one of the big questions is, do we give immediate adjuvant therapy after low-grade glioma diagnosis? So trying to decide what are the high-risk low-grade tumours that are going to progress fast versus what are the more indolent low-grade ones. So that's something that a biomarker would have major advantages for. So it's really just a blood test, and there's lots of different things you can look at in the blood. There are other cancers where the biomarkers have made significant progress, as in modern genetic biomarkers. So there are old biomarkers, like the most well-known one is like PSA for prostate cancer, but not very reliable. But in recent years, it's been genetics. So the main thing people have been looking at is ctDNA, so circulating tumour DNA. And the advantage of that is that it's very specific. You can look at the tumour mutations in the blood, and there's our group in Melbourne, our colorectal and breast cancer group have been pretty big at the forefront of that over the years. So we've sort of been following in their footsteps. So they've got a clinical trial of ctDNA in colon cancer that's going on at the moment, based out of Melbourne, called the Dynamic 3 trial. So that's following ctDNA and trying to predict when the cancer is going to return kind of earlier than imaging would normally tell you. So how could we use a biomarker in brain tumours? So that there's a few time points where it might be important. We might be able to do early detection and screening. I think this is probably one of the more unlikely time points. Brain tumours are pretty rare, so we're not going to go around screening the general population for them probably. Although there is a group in Edinburgh that has published a few papers recently on a spectroscopy blood screening test that they've sort of designed to help GPs, family doctors decide whether to do an early scan or not. I think that's a bit controversial about the use of that. So then the two things I've mentioned already are assisting the initial time point when the patient comes in for diagnosis to help prognostication together with, for instance, histopathology, and then the monitoring the patient post-operatively. And that could include things like trying to decide between pseudoprogression, radiation necrosis, those problems that we get with diagnosing on MRI, as well as potentially helping to determine the molecular characterization of the tumour in some way. So one theoretical advantage about biomarkers is that when we take a biopsy at surgery, we're only taking a small sample, and the sampling error is a big issue. We're not taking the whole tumour. Whereas a blood test can theoretically kind of give you a picture of the whole molecular pattern of the tumour and potentially be a bit more indicative of what's going on in the whole tumour. So I've talked a bit about DNA. People have also reported glioblastoma tumour cells, but they're difficult to really determine what cell comes from the tumour. There's no real known surface markers for glioblastoma. People have reported looking at some cytokines or other peptide factors. Circulating endothelial cells was popular a few years ago, but again, very difficult to determine what's an endothelial cell. And then circulating tumour DNA I've mentioned. And then we've been focusing on serum microRNA. And microRNAs are small RNAs that are heavily involved in cell regulation. There are some known microRNAs that are up or down regulated in glioma, and they're very stable in the blood. So that's why we decided to look at them. So you might say, why don't we look at circulating tumour DNA in glioma? And the reason is mainly because of this paper that came out a few years ago by Gowda, who looked at levels of DNA in all sorts of different cancers. And you'll see there that glioma came out at the bottom. So there's a big problem with low levels of DNA from gliomas in the blood. So there's a sensitivity issue with DNA. Now this was done a few years ago. There's a few more modern sensitive techniques for DNA that might improve that we're looking at the moment. But yeah, that's the reason why we've switched to focusing more on serum microRNA rather than DNA, like in other cancers. So yeah, microRNAs, they're short RNAs and thought to be regulators of protein production in the cell. There's over 2,000 or 3,000 of them that are known, reported in humans, and they can easily cross the blood-brain barrier, and they're very stable in the circulation. So theoretically, they represent a good biomarker. Right? So looking back at what people have done in glioma before in microRNA, there's been about 15 papers, but they really just focused on one microRNA and got a variety of different results, so nothing very definite. So that's why we sort of took this on and wanted to do a much more comprehensive study. There's a few problems with microRNA, like there's no endogenous controls, no really set methods or standardized methods for doing it. And no studies at all had looked at using microRNA for post-operative monitoring. So this was just our meta-analysis that we published a couple of years ago. So we showed that using single microRNAs, you could get about an 87% accuracy in diagnosis. That's really just comparing glioma to healthy control patient serum. So in our study, we had a cohort of 91 gliomas that were followed over many years. So one of the things with this kind of study is that it's very costly in terms of time and human effort, because it takes a lot of people to follow the patients and take a lot of blood samples. So this really took us about 7 or 8 years to get all of the follow-up samples. We ended up with 350 blood samples. And then you've got to go back and look at all the radiology, do the volumetric analysis on the MRI. So we basically followed those 91 patients over time. We also had 17 healthy controls. We looked at the microRNA. We wanted to do a widescreen sampling of the microRNA, and we used a new technology called nanostring, which basically profiles 800 known cancer microRNAs. Because we didn't really have any idea of which microRNA would be important. So we wanted to do a very wide screen assessment. This is just a summary of the cohort. We had about half low grade, 46 low grade patients and 45 high grade patients. And they were pretty standard in terms of their age and gender and survival. You'll see that the low grade patients had a median survival of 68 months compared to only 16 months for the high grade patients. And again, the IDH mutation positivity rates there. We had quite a few secondary glioblastomas in this cohort, so there's a fairly high IDH mutation rate. And that probably reflects the fact that there was a bit of selection bias to picking the longer surviving GBMs that were around to come in and have blood tests. I'll skip that slide. Looking at the microRNA profile then, this is the most interesting thing really that I think shows that the microRNA biologically kind of copies the pattern of the brain tumour. So you see on this this principal component analysis that just looks at the whole profile of microRNA, you'll see that it nicely separated out the group of low-grade patients. The group of GBM patients, which are the red dots, they were much more heterogeneous. And the healthy control patients were really all clustered here in a completely different pattern. So there's definitely a difference in the microRNA patterns between the tumour patients and the healthy control patients. And you can see that on the heat maps as well, if you compare the low-grade and the high-grade patients to the healthy controls. So one of the issues with microRNA is normalization. We had some nice assistance from there's a medical research institute we work with, the Walter and Eliza Hall Institute, where the biostatisticians have come up with a new normalization method. So one of the problems when you're doing this kind of widescreen gene profiling is batch effect. So you'll see every batch there in a different color has a slightly different kind of baseline. So their method was able to flatten that out and smooth it out so that we can compare across tests across years much more accurately. So these were the actual microRNAs that came out top in our diagnostic signature. We did it twice. We had a signature one was just using kind of standard biostatistical methods, like differential gene expression methods. And signature 2, we actually tried a machine learning method, which is sort of a Monte Carlo method where you go through thousands of iterations looking for a test set and a diagnostic set compared to a test set. And interestingly, they both came out with the two microRNAs that were on top there. It was 320E and 223. So that was kind of a nice validation of both methods showing what the top microRNAs were. And when we put that signature in, it had an extremely high accuracy. So the area under the curve there actually came out as 1. This graph here just shows that if we add 9 microRNAs into the mix, you get to an accuracy of 1 very quickly after 9. And by adding more microRNAs to that test diagnostic signature, we don't really improve the accuracy much. So 9 seemed to be like the optimum number of microRNAs that helped us get to diagnosis. And then when we looked at that in the 91 glioma patients, following them along in their post-operative time course in this region, we actually confirmed the nanostring microRNA numbers using droplet digital PCR. So that was with a second sort of more standardized method. The other thing is that PCR is going to be the method that we would potentially use in the clinic. You don't want to use an expensive, deep gene sequencing method for an everyday test. It's going to end up being a PCR test that can be done very quickly on samples with a handful of genes. That's going to be like the practical method for a potential blood test for gliomas. So we look at the actual comparison results of the microRNA. First, microRNA 223 as a marker of low-grade glioma. Now these are pretty preliminary results. The numbers are pretty small because it really does take a lot of data to get the accurate statistics on this. But you'll see that in many cases where the patient's tumour was increasing in size and then they had surgery, which is the black arrow, the microRNA also went up and then down again when they had the tumour resected. Same for this one. But this one here was increasing. It didn't seem to have much response at the initial surgery, but then it started to increase and then the tumour started to increase. We don't know what happened after that. And the same pattern in this one. There seemed to be a pretty consistent pattern that the microRNA was following the tumour size. And same with the 320E microRNA with GBM. So the really interesting thing though is that we found 2 patients. where they had pseudoprogression. So you'll see the tumour looked like it was gone, and then there was a large enhancing mass that came back, and then without any specific treatment apart from steroids, the tumour went away. So the clear case of pseudoprogression, there were 2 cases like that in our series. And interestingly, they were the ones where the microRNA marker did not rise. So you see it stays pretty flat as the tumour size increases and then comes down again. So it could be a really nice way of helping us decide when the patient's going to be a pseudoprogression case or not, which I think would be a pretty clinically important thing to help out. So in conclusion, liquid biopsy in general, or a biomarker for brain tumour, has potential to have huge clinical advantages. And the question is really just what we need to look at in the blood. So we're going to continue to look at microRNA. I think those microRNA results are really interesting, and we're looking at them in a further prospective cohort study. But we need to sort of refine the normalization and the protocol. So just got a couple of my last slides is on the other question. So the other question is, what I've talked about is using this microRNA blood test for monitoring post-operatively. The other question is, how do we use it at the initial diagnosis stage to help prognosis? So we all see cases like this where there's a low-grade glioma, pretty much the same age, the same diagnosis, grade 2. One has an overall survival of only 28 months, and the other one's still alive 9 years later. So there's huge variation in these tumours. And same with GBM. We can see GBMs that look pretty much the same age, both IDH wild type. One is only surviving 16 months, the other one's still alive 7 years later. So there are some GBMs that do very, very well as well. So we've just done a very preliminary analysis on this so far. We're working on it at the moment, but you can see that grade, if we look at the Cox regression model, the hazard ratio of the grade, our standard grading score, is still very, very good. IDH1 mutation is good as a survival predictor as well. And microRNA, there is somewhere in the mix. So we're just trying to figure out whether it really is going to be an advantageous addition as a blood test to put into this kind of prognostic schema, but we're not sure yet. So that's an upcoming project. So thank you very much. I think that, in the future, this is going to be something that's going to be probably incorporated into our clinical workflow, looking at the blood test at the same time we do the initial surgery and take the tissue biopsy and look at the MRI. The other thing is using it to sort of determine more personalised targeted therapies and treatments in the future. So thank you very much. This is just an acknowledgement slide. All the people that have been involved in this project over the years, and these are various funding bodies that we have around Australia. Thank you very much.
Thank you. That was wonderful.
Super impressive work. And the implications for this, I think, is kind of everyone who deals with glioma's dream, right? All of a sudden, you can follow a simple blood test that they're going to get anyway with their chemotherapy. And even as the scan starts to look worse, you at least feel comfortable that your test suggests that this is maybe pseudoprogression, not recurrence, at least can guide you. Of the stuff you've looked at now, I mean, it sounds like you haven't started yet, but preliminary evidence at all on, prognostic, specific mRNAs that relate to prognosis more so than others? Are there ones that you've looked at, or are there ones you haven't looked at that you think matter more? Or?
Yeah, we've looked at it, and we've got a list of sort of candidates at the moment. There are some microRNAs that kind of tend to come out top. The interesting thing about this kind of project that I've discovered is that statistics is a very vague science, and there are many different ways of looking at it. And every biostatistician has a different personal method that they say is the best. So we've actually got 2 groups of biostatisticians at the moment that are kind of working on it, and we're sort of getting them to compete against each other, see who comes out with it.
I think it's probably the best idea. You know, just because our viewers are not only people who, you know, do research or not just neurosurgeons, there's a lot of students involved too. Can you explain a little bit about, you know, what are the microRNAs? Are they coming from the tumor? Are they coming from a patient-specific response to the tumor? You know, obviously this 320, this is a universal kind of sign, it seems, in a way. And so is there any evidence or suggestion as to where this comes from within the tumor itself, or why it generates it?
So yeah, I mean, microRNAs are in all of our cells. So the question is that, and this is one of the problems, the question is that other microRNAs we're seeing in the blood, you know, specifically directly the ones from the tumor. I think all we can say is that statistically there are certain microRNAs in the blood of glioma patients that are, you know, extremely upregulated in general compared to healthy patients. So we all have background microRNAs, but that 320E and the 223 and the others seem to be the ones that are upregulated. Now then the question is, are they upregulated specifically in brain tumor cells? We don't know that at the moment. There is one previous paper that shows that 320E is upregulated in colorectal cancer cells.
Yeah, that's what I was going to ask next, basically.
Yeah. Probably the most well-known microRNA in brain tumors is 21. And that's come up in multiple papers, and that has been shown to, you know, be upregulated in actual glioma cells, like is in cell cultures and things, and in tissue. And it probably plays a role in regulating the growth factor pathways, is what it's thought, as in it's linked to sort of the EGFR pathway, which is well known in gliomas. But nobody really understands the direct function of those microRNAs.
Yeah.
So there's a little bit of talk about targeting various microRNAs, like you can now do CRISPR, or you can now put in you know, targeted RNA inhibitors that can just knock down a particular microRNA. There's been a lot of talk about doing that in gliomas, but nothing's really come up yet. Yeah.
And have you guys looked at all?
The microRNA 21 did come up in our signature, but at a lower level. It wasn't one of the top ones, but it's in there.
What about with the sort of the advent of all these different therapies utilizing the opening the blood-brain barrier, you know, whether it's chemotherapy and sort of in a recurring model? What are your thoughts on using this type of test in that sort of treatment paradigm where they're saying getting serial treatments over several months?
Yeah. I think that could be potentially very useful. I mean, yeah, there's a number of thoughts about opening the blood-brain barrier, like using ultrasound or using bubbles, various things like that. And it'd be very interesting to see whether these blood biomarkers increase or decrease, you know, pre and post a sort of blood-brain barrier therapy. So it could be potentially used as a biomarker for that. Yeah. There's a concept known as companion diagnostics, where you have a treatment and then you have the blood test marker that goes along with that therapy, which is, I think, a good concept and what's going to happen in the future. So, I mean, the circulating DNA is a nice thing that we're starting to look at again, as I said, at the moment. The big advantage of DNA is that we already know what the mutations are. So, for instance, if you find an IDH mutation in the blood, you know it's going to come from the brain tumor, because, you know, there's no IDH mutation normally in healthy cells in the body. Or if you find an EGFR, you know, V3 mutation or a TERT mutation or something like that, it's got 100% specificity for the brain tumor, particularly. So that's a big advantage if we can get that to work.
Yeah. And sorry, guys, I got kicked off for a second there, but yeah, I think really strong work. Obviously, like you said, there's a lot of people looking into this. I think that the implications for treatment and management of gliomas is fantastic. It's incredible that this is both for low grade and high grade tumors. Obviously, a ton of work to do on this, but just like any good research, I think it asks a ton of new questions and keeps people interested, right, and moving forward. So we're approaching the end. Thank you so much again. Like I said, this will be up on YouTube. You can share the talk with your colleagues. it'll be up on Instagram Live, or it's been up on YouTube Live now as well. And just wanted to extend our thanks again for being a part of this and for publishing in the JNO also. So.
Thank you, guys.
Pleasure. Thank you. It's great to talk. And thanks for listening. Cheers, guys.
Take care.
Cheers.
Stay safe.